important topic, that is acute abdomen. So from today onwards, we are entering into the anterior abdominal wall and the abdominal cavity. Frankly speaking, hernia is also part of that. Okay, but this is a real, discussion of the abdominal contents. Now, let's start with the definition of acute abdomen. Very, very important class this is. This is a bit of mixture of theoretical as well as practical discussion. The acute abdomen is defined as abrupt onset of abdominal pain. Okay, abrupt onset of abdominal pain, usually accompanied by one or more peritoneal sign like rigidity, tenderness, with or without rebound, and involuntary guarding. Let me clarify this. A person has come to the emergency department with complaint of abdominal pain just for 1 hour duration, and before 1 hour he was absolutely all right. Okay, and he was complaining the pain, okay, around the umbilical area, pain around the umbilical area, a little bit of nausea and vomiting as well. Okay, and then when you examine, the person has also tenderness in the right, okay, iliac fossa. That area is, isn't it, around the appendix site. So this is one of the very good example of acute abdomen case. So see this? This is the abrupt onset of abdominal pain, usually accompanied by one or more peritoneal sign like rigidity of the anterior abdominal wall muscle, tenderness, and involuntary guarding. Now, some of the students may be confused with rigidity and guarding. So let me clarify you right here. Rigidity is the spasm of the muscle, okay? The spasm of the muscle. Now what happens? There are two types of spasm here. One, when we, okay, when we are about to examine that area, patient feels, okay, patient feels that, yes, now I am going to have pain. I am going to have pain. So patient voluntarily contract the abdominal wall muscle. Okay, this is known as rigidity. This is voluntary rigidity. Whereas guarding is involuntary. This is because of irritation. Okay, irritation of those muscles. And if a peritoneum is inflamed, the muscle which is overlying that area is definitely developing spasm. This is involuntary. This is known as guarding. So sometimes, they both are interchangeable term. Don't give so much importance to this difference because both are spasm of the muscle, whether it is, on its own or, or a patient is doing it, right? So things is same. But if your teacher asks, okay, remember this difference. Most cases of acute abdomen are surgical. There are a lot of medical causes of abdominal pain also. We are going to talk about that. But whenever we talk about acute abdomen, most of these cases are surgical. Let's move on. Now, all of you, please focus on this slide. These are the possible causes of acute abdominal pain. Okay, these are the surgical causes. So to make it easier for you, they have divided into different groups: inflammatory causes, obstructive causes, ischemic causes, and perforation. So see this, among the inflammatory one, inflammatory bowel disease. So what are the two types of inflammatory bowel disease we have? What are the two types?
Crohn's disease, ulcerative
disease.
Very good.
Crohn's disease and ulcerative colitis.
Absolutely. Crohn's disease and ulcerative colitis. Crohn's disease and ulcerative colitis. So they can cause acute abdominal pain. So that is one. Another one is acute appendicitis, probably the most common cause of acute abdomen in the clinical practice. Acute appendicitis. Acute diverticulitis. So diverticulum is inflamed here. That diverticulum is very commonly found in large intestine, especially in the sigmoid colon area. And sometimes even Meckel diverticulum is considered a part of that. But usually that is considered separately. See this, Meckel's diverticulitis. So if only diverticulitis is mentioned, then it usually occurs in older people where there is a history of constipation, and if it usually occurs in the left iliac fossa region. Acute pancreatitis, inflammation of the pancreas. Acute cholecystitis, acute inflammation of the gallbladder. Acute cholangitis, acute inflammation of biliary duct, okay, the common biliary duct usually. So these are some of the important causes. Now from the obstruction, we have intestinal obstruction, maybe small bowel or large bowel. We have biliary colic, obstruction of the bile duct, ureteric colic, obstruction of the ureter, and acute retention of the urine. When bladder is acutely obstructed, there is no flow of the urine outside. All of these can also be causes of acute abdominal pain. These are intermittent type of pain. Acute retention of urine can have continuous type of pain because of the over distension of the bladder. From the ischemia, we have mesenteric ischemia. Okay, mesenteric ischemia. Now remember the blood supply of our bowel. There are three main blood vessels which supply our GI tract. These are celiac trunk, superior mesenteric artery, and inferior mesenteric artery. Okay, celiac trunk supplies the foregut derivative, superior mesenteric artery supplies midgut derivative, and inferior mesenteric artery supplies hindgut derivative. So if these arteries are blocked, especially the superior mesenteric artery, which has high chance of blockage, it will lead to mesenteric ischemia. The bowel may die as a result of ischemia. Torsion of a viscus, the twisting of a viscus, and which type of intra-abdominal organ can be twisted? Okay, can you answer me? Which type? Which are the example which can be twisted? Yes.
Sigmoid colon on its mesentery.
Right destined by bot mainly, sir.
Excellent answer. Sigmoid colon can be twisted on its mesentery. The whole small bowel can be twisted on its mesentery because the mesentery is supporting it. So whatever structure is having mesocolon or mesentery, they can be twisted. Ovary can be twisted. Okay, there's the ovary. Ovarian has a stalk there throughout that can be twisted easily. So these are some of the example here. Now another one is perforation. See this perforation of peptic ulcer, usually duodenal ulcer, is common to perforate. Perforated diverticular disease, okay, the diverticulum which is inflamed can be perforated easily. Perforation of the appendix, this is a common complication of acute appendicitis. Toxic megacolon with perforation. This toxic megacolon is a complication of inflammatory bowel disease, especially ulcerative colitis. There is a huge dilation of the colon. It can perforate anytime. Acute cholecystitis and perforation. This is a complication of acute cholecystitis. Okay, and when it is perforated, remember there is passage of the stone into the small bowel. Perforated esophagus probably occurs during some sort of investigation. Okay, like upper GI endoscopy. Perforated bladder, this is urinary bladder. Perforation of a length of strangulated bowel and ruptured abdominal aortic aneurysm. All of these can cause acute abdominal pain. Okay, so in this class, we'll talk about how to approach, how to take history, how to do physical examination, how to do investigation, and at the end, we'll talk about some important types of acute abdominal pain. Now, at the same time, we should know what are the non-surgical causes of abdominal pain as well. In other words, what are the medical causes of abdominal pain? Very, very important question in the Viva exam. See here. So myocardial infarction is one of the important one. MI, especially the inferior wall MI can give rise to pain in the epigastric area. That's why if a patient is above 30 to 35 years, and if that patient is complaining of epigastric pain, always do one ECG before discharging this patient from your hospital. always, though you are quite sure this is a case of peptic ulcer disease or gastritis, still do one ECG. Make sure there is no angina or myocardial infarction, and then you are quite safe. Why? Because lower or inferior wall MI can lead to epigastric pain. Never forget this golden statement. Otherwise, we will be in real trouble. You think this is a case of peptic ulcer disease, you have given a good treatment for that, like ranitidine, whatever drug, or a PPI and things like that. But the patient has died on the way back home. And who will be responsible? The family will come back to you. That yes, my patient has come to you and you have failed to diagnose this patient. So never forget this. Always do ECG. Not in young people like you. I'm not saying like that. After the age of 30 to 35, there is a chance of ischemic heart disease because of probability of atherosclerosis. That's why we need to go for this. The second one is mitral smudge. Anybody can tell me what is this? Mitral smudge?
Sir,
Sir, on the 14 days of menstrual cycle or ovulation, the lower part of the abdomen.
Basically, it is a one-sided lower part associated with ovulation and menstrual cycle. Sir, it's come in between the menstrual cycles, so mainly on the 14 days, or most probably. And sir, it is a one-sided lower abdominal pain.
Very good. Both of the students, okay, I have heard them and they're absolutely correct. You just simply say, this is pain of ovulation. This is pain of ovulation. Ovulation occurs exactly at that time what we are describing, 14th day. If the cycle is quite regular, if a cycle is 28-day cycle, 14th day is the time for ovulation. And during that time, there is slight amount of, or a type of pain in the abdomen, intra-abdominal wall. This is called mitral smudge pain. It is not very serious type of pain. It can be, the lady doesn't need even some analgesic there. Third is a lead poisoning, especially in children. Lead poisoning is very common in a child because of their habit. Some of the child has, this habit of eating, non-edible substances. Sometimes they just keep on biting their pencil. Sometimes they keep eating some of the paint. Okay, they take out some of the paint from the wall and they chew or swallow it. So these are the risk factors for lead poisoning. And always remember one important point. This lead is a type of heavy metal, and then it can have so many clinical features in case of overdose or poisoning. One is neurological features, okay? While hematological features are also there, and abdominal pain is also quite common. Herpes zoster. See this. This herpes zoster is caused by varicella zoster virus. Okay, the causative agent is varicella zoster virus. Now, the same virus which causes chickenpox during the childhood. If the immunity becomes poor when that person becomes adult, then the infection is known as herpes zoster. It causes severe pain in a dermatomal fashion. In a dermatomal fashion, there is a severe pain there, burning type of sensation. This is herpes zoster. Very, very easy to diagnose. Once you see, you'll never forget it. And the treatment is acyclovir there. Another is lower lobe pneumonia. Now see this. This is a, I want to give you one real, case which I have seen in the hospital. When I was doing my master degree, okay, in a pediatric hospital, then in the emergency department, one child was brought by the parents. The child was having rapid breathing, faster breathing, and child was having severe pain in the abdomen. Severe pain in the abdomen. The child was vomiting as well. So the doctor, okay, the medical officer, I should say, was working there, did not think at all about the chest problem. They only focused on abdominal problem, and they sent the patient for abdominal X-ray. Okay, abdominal X-ray, because they thought, it may be a case of intestinal obstruction or something like that, and it may be picked by abdominal X-ray. And when the report come, okay, there's nothing in the abdomen. So they called me. I was a resident there. I was in second year. So they called me, and I saw that, and quickly my eyes go to the lower part of the lungs, which are included even in the abdominal X-ray. Remember, the lower part of the lungs are included there. The dome of the diaphragm are also included. So on the right side, okay, of the lung, a right lung, on the lower aspect, there is a big patch of the pneumonia there. So never forget this description which I just told you. It is a embarrassing situation if you miss that particular finding and focus only on the abdomen. Always think about the chest, especially in case of abdominal pain. So lower lobe pneumonia is an important cause of abdominal pain. Endocrine, like Addisonian crisis and diabetic ketoacidosis. The Addisonian crisis, okay, occurs in Addison's disease. Addison's disease. This is a severe lack of the glucocorticoids in the body. Well, diabetic ketoacidosis is a complication of type 1 diabetes. Okay, so both of them can have abdominal pain because of different reasons, of course. Okay, different reasons are there. Sickle cell crisis, we just talked about this. There is ischemia occurring everywhere, even in the abdomen. Porphyria, acute intermittent porphyria causes abdominal pain. Acute intermittent porphyria. This is a disorder of heme. And psychological, or also known as a hysterical problem. Nothing is there inside the abdomen, no pathology whatsoever. We have done extensive investigation. Still, that lady or a girl, these are the common patients, are complaining of abdominal pain. Okay, so these are important non-surgical causes of abdominal pain. Rather, it will be taught also in internal medicine when you talk about the abdominal diseases. Probably the first few topics will be based on this. Now, once again, let's talk about some selected causes of acute abdomen. This is just a bit of revision for you. Okay, so we can go a bit quicker here. Traumatic causes may be blunt or perforating trauma to the stomach, bowel, spleen, liver, or kidney. So traumatic cause. Inflammatory causes like appendicitis, cholecystitis, pancreatitis, pyelonephritis, pelvic inflammatory disease, hepatitis, mesenteric adenitis, or a subdiaphragmatic abscess. Many of them are inflammatory or infective condition. So I don't need to explain any of them. By this time, every student knows what is the meaning. See this? So PID or pelvic inflammatory disease occurs in female. This is the infection of internal genital organs there, like fallopian tube and the uterus itself. Mesenteric adenitis is the inflammation of the mesenteric lymph node, and subdiaphragmatic abscess is the collection of pus below the diaphragm. Perforation of peptic ulcer or diverticulum or the cecum, and complication of inflammatory bowel disease like Crohn's or ulcerative colitis can also be considered under inflammatory one. There are different types of classification, okay? Whatever you want to follow, it's up to you. But when this question is asked, you have to answer some of the causes. That's it. Regarding the mechanical causes of acute abdomen, there may be small bowel obstruction secondary to adhesion caused by previous surgery. That's why you have to take a good history when you are examining the patient. Was there any surgery done in the past in the abdomen or not? Very, very important question, because of the adhesion. Those adhesion are the causes of intestinal obstruction. Intussusception, hernia, benign or malignant neoplasm, all of these can lead to acute abdomen, probably because of bowel obstruction as a result of pressure or some other mechanism. Large bowel obstruction caused by colorectal cancer, inflammatory bowel disease, volvulus, and fecal impaction or hernia. Volvulus is a twisting of the bowel around an axis. Fecal impaction is the constipation. A hard stool is blocking the flow of the contents. Vascular, occlusive intestinal ischemia, usually caused by thromboembolism of the superior mesenteric artery. This is known as mesenteric ischemia. So these are some of the selected causes of acute abdomen. Now I'm entering into the important part, okay? And this is what the students should learn. These are very easy, what we discussed till now. But this is a bit of challenging for us because our history should be quite particular and precise, And that should guide us towards the diagnosis. The first question is, where do you hurt? What is the site? Where is the pain? Now, if the patient say, okay, I am having pain around the umbilicus, that is a very good description they are giving. Or patient may say on the upper part of the abdomen on the right side, lower part of the abdomen on the right side, lower part of the abdomen on the left side, or upper part of the abdomen on the left side. Patient may answer like this. But as a medical student or as a doctor, we know what are they saying, because we know what are those regions, which organs are present underneath them. That all we know. So we know what may be the cause of the pain. Okay, so this is the first question. We must know the location of major organs, okay, but realize abdominal pain location do not correlate well with the source. Sometimes there may be referred pain. Sometimes pain may start from some other area. So that point is always there. But having said that, usually it originates from the organ which are lying there. Now, okay, so what I'm describing here, after you go through this slide, it is very well known to you. Now, see this? If the patient is complaining of pain in the epigastric area, these may be the causes. Peptic ulcer perforation or simply peptic ulcer and pancreatitis, the common one. Okay, there are so many other, but the only common one are highlighted here. If patient is complaining of pain in the right upper quadrant, then it may be because of gallstone, it may be because of cholecystitis, it may be because of cholangitis. Right flank and left flank, this is for kidney area, kidney. So any disease of the kidney or the ureter can have pain here. So see this, ureteric colic, pyelonephritis. Okay, these are the important ones. So many others. Right iliac fossa is for appendix and cecum. So see this, appendicitis, obstruction of the cecum, ectopic pregnancy, because even fallopian tube and ovaries are located, in this area. So ovarian cyst, ectopic pregnancy, and Crohn's disease of the terminal ileum. Okay, terminal part of the ileum is most commonly affected by Crohn's disease. So these are some other causes here in the right iliac fossa. Now, what about the suprapubic area? Pain occurs, then we think about cystitis, urinary retention or acute urinary retention. That means acute obstruction of the urinary flow from the bladder. That is the most common cause, as well as torsion of the testes. That can also, give rise to suprapubic area pain. In the left iliac fossa, we have diverticulitis. I already talked about, because sigmoid colon is the most common part of the intestine where diverticulum can form, especially in the older people. Constipation itself, ulcerative colitis, ectopic pregnancy, because another fallopian tube is present on that area now, and ovarian cyst as well. Left flank is the area for kidney, and left upper quadrant, okay, is especially the site for spleen. Okay, it is especially the site of the spleen. So any types of splenic diseases or condition can have a pain there. Whereas periumbilical area is, having pain. If that is having pain, then we think of appendicitis in the early case, because in appendicitis, pain always starts from the periumbilical region, and then later on it moves on to the right iliac fossa, small bowel obstruction, and even gastroenteritis. Okay, though this arrow is shown here, many of this pain doesn't occur here. So these are, some of the causes of abdominal pain. Let's move on. Now we are talking about the history in case of acute abdomen. So we need to find out whether this is a visceral pain or parietal pain. Visceral pain or parietal pain. What are the differences between them? Let's talk about it. Visceral pain occurring from the involvement of visceral organs or because of involvement of visceral peritoneum, visceral layer of the peritoneum. So this is a poorly localized pain, okay, poorly localized, usually dull aching type of pain. This is not sharp at all, and this pain mainly develops from the distension or spasm in hollow organ. Example is crampy pain, which is felt during early intestinal obstruction. Okay, so this is a visceral pain. Now, one important point I like to highlight here is the visceral pain, especially from the intestine, doesn't occur in other situations. For example, if we cut the intestine, there will be no pain. But when intestine is distended or it is contracting, then only during that time there will be pain. This is quite typical. If pain in the mid-epigastrium, then stomach, duodenum, hepatobiliary system, or pancreas disorders are suspected. If it occurs in the mid-abdomen, then jejunum and ileum pathology are suspected. Mid-abdomen means around the umbilical. And if it occurs in the lower abdomen, colon, okay, and internal reproductive organs disorders are, thought. We already talked about these in the previous slide. Now, what about the parietal pain? It is sharp, it is well localized, and it is a somatic pain which is arising from the irritation of parietal peritoneum. This is important one, which is supplied by many nerve fiber. And this irritation is usually done by pus, bile, urine, or any GI secretions like acid, like hydrochloric acid. When there is a perforation of the peptic ulcer, that hydrochloric acid is leaked into the peritoneal cavity, and that can easily lead to parietal pain. One of the example of the parietal pain in our anterior abdominal wall is because of the inflamed appendix, it causes sharp right lower quadrant pain due to irritation of the nearby parietal peritoneum. Now, further information regarding this, which will make your concept very clear. Okay, please listen it properly. In the beginning, okay, in the beginning case of acute appendicitis, remember there is some obstruction of the lumen of appendix, probably by the fecalith. Okay, fecalith. Now what happens? There is distension of the appendix. That distension of the appendix will lead to visceral pain, and this visceral pain is felt around the umbilical area. Now later on, when infection increases there, then it will lead to irritation or the involvement of parietal peritoneum in the right iliac fossa region. Now, after that, the pain shifts to the right iliac fossa and it becomes sharp and localized pain. This is the perfect scenario of description of visceral pain and parietal pain. Let's move on. Now, when we take the history, okay, these are some of the important guidelines for you so that, some of the students may like to, remember with the help of some mnemonic. So take it like a mnemonic here. Assessment of pain should include PQRST. P stands for precipitating or palliative factors. Precipitating means aggravating factor. Palliative means relieving factor. Also understand like that. Ask about the quality of pain. What type of pain? Stabbing pain, shooting pain, boring pain means it is going backward. That is called boring type of pain, a dull type of pain. Ask about the radiation of the pain, where it is going to the other side, okay, other parts of the body. Where? Is it going towards the left shoulder or right shoulder? Is it going towards the back or is it going towards the thigh? Okay, something like that. Ask about the severity of the pain. Now, severity means you can easily ask in the scale of 1 to 10, okay, which grade the patient will choose. 5 below towards the 1 is a less severe pain. 5 towards 10 is a severe type of pain. And if sleep is disturbed or not, if the person can sleep with pain, it is not very severe. If the person's sleep is disturbed, then it is considered moderate to severe type of pain. These are very important practical points. Timing, what time? Okay, exactly. Is it in the morning time, daytime, night time? These are also important regarding some type of pathology. But though it is not a very important point here. Now, one of the example which is included here, just to make your knowledge clear, is okay, Kehr's pain, a Kehr sign is pain referred to the left shoulder due to irritation of the left hemidiaphragm, and it is often seen with splenic rupture. What is happening here? Spleen is ruptured either because of trauma, okay, or because of some pathology inside the spleen. After that, the blood will leak outside. That hematoma has caused irritation of the left hemidiaphragm, and because of this, the pain is felt in the left shoulder area. This is a perfect example of, referred pain. Now, let's talk about another part of the history taking, the quality of the pain. So what about that? Gradual and steady pain occurs usually in this condition: acute cholecystitis and hepatic abscess. Whereas abrupt and excruciating pain may occur in perforated peptic ulcer, ruptured aneurysm, ureteric colic, and strangulated bowel. All of these you already know, so I don't need to describe what is the meaning of this term. Okay. Now see there, intermittent and colicky pain occurs in small bowel obstruction, acute cholangitis, inflammatory bowel disease, and biliary colic. Now there is a common thing in all of these structures. What is a common thing in them regarding the structure? Yes, anyone? What type of anatomical structures are they?
Sir, all are, sir, mainly that abdominal, sir, the intestine and the biliary regions are mainly, majority of them are that one, sir.
Okay, fine. They are the tubular structure. They have got a tube, they have got a lumen inside. Now see this, bowel is intestine. This acute cholangitis is the inflammation of bile duct. So we are talking about the duct there that has got a lumen. Inflammatory bowel disease again occurs in the intestine, and biliary colic, okay, again occurs inside the bile duct. So remember one point here very clearly: if any tubular structure which has got a lumen, if that is developing spasm or the contraction, colicky pain occurs, which is intermittent definitely. If gallbladder pathology occurs, there will be colicky pain. Whole GI tract will result in colicky pain. Urinary bladder pathology will also result in colicky pain. Ureter pathology will cause colicky pain. And biliary duct pathology also will have colicky pain. Never forget this. Now, another one, rapid onset, severe and constant pain that occurs in acute pancreatitis, ectopic pregnancy, mesenteric ischemia, diverticulitis, and acute appendicitis. Now, this is a little bit difficult for the students to remember, but don't worry, okay? Just take a history and find out there is pain or not. That's it. In the clinical practice, it has very less significance except the colicky type of pain, because it is very easy to take the history. Colicky pain comes and goes. It will be there for a few minutes or few hours. Then after that, again, the pain will come back. Okay, and it signifies the tubular structure is affected there. Now, some other history. What are the precipitating or palliative factors? Which position will cause pain? And what change in position will not increase the pain? This is a very important question, especially in the abdomen. Okay, for example, peritonitis. If the person is having generalized peritonitis, the person, when they move the entire abdominal wall, there will be movement of the peritoneum that will cause severe pain. So what the patient do? They just try, learn to lie still. They don't want to move at all. This is one of the position. Association with food. Ask that question. Does the pain become better or worse after food? Now, two good examples we can quickly give here are peptic ulcer disease like duodenal ulcer and gastric ulcer. With food, duodenal ulcer pain becomes better, means the pain becomes less. And if we eat food, the gastric ulcer pain becomes worse. Pain that wakes one from sleep is a significant pain. I already talked about. The sleep is disturbed with pain. That means take it seriously. Regarding the radiation of the pain, some of the important examples are highlighted here. So let me underline them. Biliary tract pain may radiate to the right shoulder or right scapula because of irritation of right hemidiaphragm. This is biliary tract pain. Okay, it may radiate to the right shoulder, right scapula because of irritation of right hemidiaphragm, because of the similar type of nerve supply, similar source of the nerve. That is the reason. Splenic rupture pain may radiate to the left shoulder. That is called Kehr's pain, we just talked about. Kidney pain may radiate from flank to groin, and genitalia, that is called loin to groin. Okay, so flank is called loin. So if the pain is going to groin, we call it loin to groin pain, and this is highly suggestive of kidney stone pain or kidney pathology pain. And if ureter is also having some obstruction, similar type of pain may be there. Very, very important question. And then pancreas pain may radiate to the backside. Okay, because pancreas is an organ which is known as retroperitoneal organ. So pain usually refer to the backside. So this is called radiation of the pain. Let's move on. Now, what are the associated symptoms along with pain? Now, this also gives a lot of information to us regarding the diagnosis. If there is vomiting along with abdominal pain, okay, then you may think of so many causes. Even gastroenteritis is having some, colicky type of pain with vomiting. But gastroenteritis is a medical condition. We are not too much concerned about this here. Acute appendicitis will have vomiting along with abdominal pain. Intestinal obstruction will have vomiting along with abdominal pain. So many causes are there. So some of the important points. If pain is relieved by vomiting, that is supportive of small bowel obstruction or afferent loop syndrome. So we all know about small bowel obstruction. Duodenum, jejunum, ileum, these are the parts of a small bowel. If any of those structures are blocked or obstructed, that is called small intestinal or small bowel obstruction. So the cardinal features here are pain, vomiting, constipation, and distension of the abdomen. Okay, and pain is usually relieved by vomiting. Now, another condition is known as afferent loop syndrome. Afferent loop syndrome. Probably you may not know much about this, so let me explain here. This afferent loop is formed by gastrojejunostomy, and gastrojejunostomy is the reconstruction surgery between the leftover part of the stomach and jejunum, and this is done in case of resection of the stomach or gastrectomy. Now, when we need to go for gastrectomy, in case of carcinoma of the stomach, in case of treatment of peptic ulcer disease. Now, what we are doing here, we are, sacrificing a big part of the stomach, and the leftover part of the stomach has to be connected with jejunum. We usually do not connect it with duodenum, remember that, because of the high chance of regurgitation of the bowel. Yes, bile, I should say, sorry, bile. Because bile comes in second part of the duodenum. So if we connect that rest of the stomach with duodenum, that bile can easily reflux back. We don't want that to happen. So it is connected with the jejunum. Now, what about the leftover part of the duodenum there? First part of the duodenum, second part of the duodenum, third part of the duodenum, and fourth part of the duodenum. That is leftover. This is known as afferent loop. Afferent loop. If this afferent loop, is blocked, if it is having a lot of secretion, then it is known as afferent loop syndrome. And vomiting, if it is connected to the main bowel, then it also lead to relief of the pain after vomiting. Another important point. Yes.
Sir, in afferent loop syndrome, when we connect the stomach with duodenum, then most of the substances which are absorbed through the duodenum, sir, then there is like other complications. Sir, how we can handle this?
That's a very good question you have asked. Of course, that is a complication which the surgeon already know that these complications occur. Like especially the absorption of the iron mainly occurs in the duodenum, but it also occurs from the jejunum. Not 100% of the iron is absorbing from the duodenum, but the important point here is duodenum doesn't play that very active role in food absorption and digestion. Okay, that role is done by jejunum and ileum. That is a very satisfying and important point for us. And one more thing, or one more function of the duodenum is there. It, is a site where bile flows, and it is a site where pancreatic juice flows. That's why we cannot sacrifice it. We need to keep that segment. But food from stomach will not pass from there. Remember that. It will directly go to the jejunum. But all that bile and pancreatic juice will go distally to the jejunum, and it will mix with the food, and everything is happening in the jejunum now. So duodenum doesn't have much role in the digestion and absorption of the food in this type of surgery. Okay, we know that already, and not much problem occurs. The problems are like this afferent loop syndrome, okay, sometimes regurgitation and things like that. Okay, now if a person is vomiting bile, okay, or a green type of vomiting, bile is a greenish in color, what does that mean? It means the obstruction is distal to the second part of the duodenum, then only it can happen. If the obstruction is proximal to the second part of the duodenum, then bile will not come in vomitus. Always remember this. So this means the probably, small bowel obstruction is there, and it's the proximal part of the small bowel, maybe some loop of the jejunum or ileum. Now, regarding the bowel habit, constipation or obstipation is there or not, we need to ask. Obstipation means no stool or flatus is passed from the rectum or anal canal. It's called as absolute type of constipation. Not even the gas is passed. That is called obstipation or absolute constipation. Now, it is suggestive of bowel obstruction, there's no doubt about it. If a mucoid diarrhea is there, okay, along with blood, which is known as red currant jelly type of stool, it is suggestive of intussusception. Now, what is intussusception?
The proximal segment move into the distal segment of...
So the proximal segment of the intestine move in the distal segment of the intestine. So the sliding over of this intestine and is known as intussusception.
Exactly. Both of them are answering absolutely correctly. The proximal loop of the bowel is telescoping into the distal loop of the bowel. That is known as intussusception. It has high risk of obstruction and getting ischemic. So remember this important term, red currant jelly stool is a diagnostic point of intussusception, which is very common in children. Anorexia is a non-specific feature, okay, very non-specific symptom. It may occur early with the case of acute appendicitis, but we do not rely on this anorexia regarding the diagnosis because it is very non-specific. It is present in so many other conditions. And fever is seen in appendicitis, acute cholecystitis, or acute pancreatitis as well, but this fever is not that very high grade. It is just a slight rise in body temperature. Now, what about the other aspect of the history? Let's ask some medical and surgical history. Now, we always ask any past abdominal surgery or not. Now, any abdominal surgery done in the past increases the chance of small bowel obstruction secondary to adhesion. Even it occurs years later. Okay, adhesion is a very important cause of intestinal obstruction. Even the large bowel can be obstructed there, but small bowels are a smaller type of tubes, so there's high chance of obstruction there. Ask about the heart disease. Okay, heart disease. Now, in case of heart disease, especially the mitral valve disease or left-sided heart disease, there is a high chance of atrial fibrillation. Atrial fibrillation can result in thromboembolism, and that thromboembolism can lead to blockage of mesenteric artery, which is called mesenteric ischemia. Okay, so this is important history. And menstrual and sexual history are always asked. Ask about the sexual partner, ask about the sexual intercourse, especially the unprotected type, because acute salpingitis and pelvic inflammatory disease are a type of sexually transmitted disorder. Not always, but one of the modality is the sexual transmission. Another one is ruptured ectopic pregnancy. If you do not take the menstrual history properly, then how you diagnose ruptured ectopic? There has to be asked the question about last menstrual period, LMP, when? Usually the lady has already missed her last menstrual period by 1 to 2 weeks. Then it is highly suspected. So these are the important points. Let's move on. Now some of the points which are important are highlighted here again. Please pay attention. This is a bit of clinical class for you. Serial abdominal exam and abdominal observation may be necessary in cases in which the etiology of abdominal pain is initially unclear. Sometimes, there's some vague type of pain is there, and in the beginning we don't know what is the cause. So in this type of patient, we should observe for a bit of longer time, and serial examination has to be done. Pain of perforated peptic ulcer is severe and of sudden onset. There's no doubt about it. It occurs in the epigastric area, and Murphy's sign is seen in cholecystitis. Murphy's sign. Now, anyone can describe what is Murphy's sign to me? Maybe you have heard this before. Yes?
The pain radiates from the right shoulder to the.
Sir, basically, sir, it is a sign of acute cholecystitis, sir.
Okay, good. That much information is enough. Anybody else? Anybody? Okay, now listen here. He's right. This Murphy's sign is seen in acute cholecystitis. And how we do this? We ask the patient to lie down comfortably on the bed, okay, and draw the knee upward, means relax the anterior abdominal wall muscle. The examiner will give firm pressure on the gallbladder area, that is tip of the 9th costal cartilage, that is the gallbladder area, and ask the patient to deep breathing or take a deep inspiration. Now, when the person takes deep inspiration, because of the movement of the diaphragm below, it will push all the abdominal organs a bit inferiorly and a little bit anteriorly, so that inflamed gallbladder will hit your finger, and that time you are pressing inward. That will cause a sharp catching type of pain, and I can see that pain in the face of the patient. Patient will change the facial expression. This is known as Murphy's sign. Okay, remember this. We'll talk about this when the particular topic will be discussed. Most common cause by far, that is 90% of the free air under diaphragm, is perforated peptic ulcer. Other causes include hollow viscous injury secondary to trauma, mesenteric ischemia, and large bowel perforation. Now that is another very important concept. So let me take a bit of time here. Okay, now see this. Sometimes what happens, there is perforation of our GI tract, okay, inside the abdominal cavity. Stomach may be perforated, first part of the duodenum may be perforated, or any other intra-abdominal organs may be perforated. Now what will happen? The gas inside the intestine or GI tract will leak outside in the peritoneal cavity, and gas always goes upward. Remember that, always goes upward. So if the patient is standing, the gas will go upward and stay there under the dome of the diaphragm, because diaphragm is blocking the flow of the gas upward into the thoracic cavity. We take this type of, opportunity by taking the X-ray there and ask the patient to stand up in the erect position, take the X-ray, and we can see this gas. If this gas is seen, it almost confirms that there is a perforation of the hollow viscous. It may be perforation of peptic ulcer, it may be perforation of appendix, it may be perforation of the small or large intestine, or it may be because of the mesenteric ischemia, there is death or gangrene of the intestine, and that has also perforated. Remember this. Now, which dome of the diaphragm we'll see usually? We look for the right dome of the diaphragm, because the left side, there is a fundus gas which is already there in the fundic part of the stomach, and sometimes that gas will, cast a doubt in our mind. Maybe this is a gas which is collected inside the stomach. So just to avoid this confusion, you see on the right dome of the diaphragm, and usually it has got collection of the gas in case of perforated of the hollow viscous. Now let's move further. How to examine the patient now? How we do the physical examination after taking this type of history? We always start with general examination of the patient and examination of the vital sign, followed by systemic examination. Okay, don't forget that, a pattern you already know. So among the vital sign, so what we do here now, most patient with a surgical abdomen will have vital sign abnormalities secondary to pain, inflammation, fluid, and electrolyte derangement, as well as anxiety. See here. So most patient with a surgical abdomen, means acute abdomen, will have a vital sign abnormality either because of pain, either because of inflammation or infection, either because of hypovolemia or electrolyte abnormality, or because of simple anxiety. So there may be tachycardia, there may be hypertension, increase in blood pressure, or if the fluid is lost too much, then there is hypotension as well. There may be faster type of breathing, and there may be rise in body temperature. These are called abnormalities of the vital sign. We don't need to explain much. Every student know that. So tachycardia, it is seen in early shock or early cases of shock, more important than blood pressure, of course. Blood pressure will fall only in the late stage of the shock. And rapid shallow breathing may be feature of peritonitis. Any type of infection inside the abdomen. Now, regarding the general examination, first is the general appearance of the patient. If the patient is lying very still on the bed, very still, not moving at all, then we suspect there is active inflammation going on inside the abdomen, and maybe it's a case of peritonitis. Already talked about, in case of peritonitis, during the movement there will be pain. So to avoid the pain, patient lies very still. If the patient is restless or patient is writhing with pain, means the patient is moving different parts of the body with pain, very restless condition. This may be a case of acute intestinal obstruction, or maybe ureteric colic, those type of pain, or maybe biliary colic. A colicky type of pain is usually like this. Don't forget to examine JAL CCOD. Now, I'm sure every student still remember what is the full form of this. Yes?
Yes, sir.
Isn't it?
Sir,
so what is...
The jaundice, anemia, lymphadenopathy, clubbing, cyanosis, edema, sir.
Very good.
Number 4D.
Very good. So, jaundice, A for anemia, C for clubbing, another C for cyanosis, very good. O for edema, we write edema like this, and then D for dehydration. So these are some of the important, general examination you have to do in the patient. Always, whatever specialty you are studying or examining, whether it's a surgical patient, medical patient, pediatric patient, obstetric or gynecological patient, orthopedic patient, don't forget to do this. Another one is a mentation or higher mental function. Okay, not very important at this time, but you should quickly do it, whether the patient is well oriented to time, place, or portion or not. And quickly, comment on the nutritional status of the patient. Now, after this, we move on to the examination of the system. One of the system which is very well connected with the abdominal pain or acute abdomen is the respiratory system or the examination of the chest. I already told you myocardial infarction, okay, is one of the cause of abdominal pain. Lower lobe pneumonia is another important cause of abdominal pain, and they have the connection with the chest. That's why examine chest, simply auscultate there. Okay, you may get your important diagnosis. Now, our main focus will be on the abdominal exam, and this is the most important part of examination here. Now, how to do abdominal exam? Palpate each quadrant of the abdomen. I'm talking about a bit of general aspect first, okay, and then I'll talk about the detailed examination. Okay, just pay attention here. Palpate each quadrant of the abdomen. Now there are so many different quadrants of the abdomen. We roughly divide these into 4 quadrants actually: right upper quadrant, right lower quadrant, left lower upper, and left lower quadrant. So start from the left lower quadrant, okay, go to the right upper, and like that examine all the quadrants of the abdomen. Work towards the area of the pain. Do not start from there. This is very important principle. Work towards the area of the pain. Okay, so what does that mean? If the pain is complaint in the right iliac fossa, don't start examining from there. Start examining from the left iliac fossa, then go upward, okay, then come like a circle and only examine that painful area at the end. Warm hands are very essential, especially during the winter season. Nobody wants, okay, to be examined with very cold hands. So warm your hands, okay, rub your hands with each other, then only examine the patient. Patient should be on the back, okay, and knee should be bent if possible. It is possible usually. So what we say, lie down comfortably on your back on the bed or examination table and bend the knee so that the anterior abdominal wall muscle will be relaxed and I can examine quite nicely. If the knees are straight, there is contraction of the anterior abdominal wall muscle, so I cannot palpate easily inside. That is the reason. Note tenderness, rigidity, involuntary guarding, voluntary guarding, and different masses. Now, rigidity, okay, rigidity is similar to voluntary guarding. Then involuntary guarding occurs because of inflammation of the parietal peritoneum. The overlying muscle will develop spasm on their own, but I already told you it doesn't have a much difference. These, okay, different textbook mention differently, so you don't need to follow this. It's up to you. If you find something better than this, something which you feel easier than this, then you can always follow that. We are not too concerned about it, but the point should be there. So inspection, palpation, percussion, and auscultation, many textbook follow that order, but to make it easier so that no points are missed, it is given like this: inspection, then auscultation, okay, cough tenderness, just sometimes the herniation is there, and that hernia may be inflamed or something like that, irreducible, that this type of test is done. Percussion is another important test, guarding a rigidity, What is the difference between guarding and rigidity? Yes? What is the difference? Anybody? Anybody can tell me that?
Yes, sir. Sir, guarding, like, sir, guarding is it is basically it's a voluntary contraction of the abdominal wall musculature. The guarding, like, sir, it is a contraction of abdominal wall musculature. But sir, rigidity, it is like, sir, that hardening sort of a, and sir, like, it cannot purposely relax. It is that sort of a thing, sir.
Very good. Yeah, you have the concept. Excellent. I'm sure many other students also know this. So let me repeat it again. Guarding and rigidity both occurs, okay, in case of acute abdomen, especially if there is involvement of the parietal peritoneum. Parietal peritoneum involvement can lead to contraction of the abdominal muscle, and they are guarding a rigidity. One is voluntary contraction of the abdominal muscle, another is involuntary. Guarding is a voluntary. So remember the term guard. Okay, guarding means we voluntarily contract the abdominal muscle so that the underlying, inflamed area will not have pain when we particularly examine. For example, as a doctor, we are examining that patient. Patient feels when the doctor presses me there, I'll have severe pain. So patient voluntarily contract the abdominal muscle, okay, so that there is avoidance of the pain. This is called guarding. Whereas rigidity is involuntary, you cannot control it. And guarding occurs overall. The whole anterior abdominal wall is guarded, but rigidity occurs only in that area which is inflamed. Like acute appendicitis, it is only in the right iliac fossa there is rigidity, whereas guarding occurs generalized all over the abdomen. This is an important question your teacher may ask, and I already told you these terms are used interchangeably sometimes. Now, palpation can be done with one finger. It is rebound tenderness or deep. Now, rebound tenderness is a very important feature of parietal peritoneum involvement, especially, again, we take example of acute appendicitis when the peritoneum is involved just, above the appendix. When we press, there will be pain, but when we release our finger, the pain is even more. This is called rebound tenderness because the parietal peritoneum jumps back to its original position. So that will cause severe pain. Punch tenderness means we hit, okay, some particular area with our fist, okay, like a punching. And those two important areas are costal area for cholecystitis pain and costovertebral area for renal angle tenderness. Some other special signs has to be, examined, like Murphy's sign and Kehr sign. So the two important terms. Murphy's sign is seen in acute cholecystitis, whereas Kehr sign is seen in splenic rupture. External hernia and male genitalia have to be examined, and rectal and pelvic examinations are always a part of abdominal exam. Never ignore them. So then only your abdominal examination will be complete. Okay, so let's move further. Now, how we listen for the bowel sound. See this. The bowel sound should be listened in each quadrant if possible, but sometimes only one quadrant is enough. If you are quite sure, and if you have listened for at least 1 minute, and you have heard a bowel sound, then it's enough. But if you have not heard any bowel sound, you need to listen a bit more. In some of the textbook, it is even written up to 3 minutes. Okay, so during that time, it's nice if you change the quadrant. Always listen the bowel sound before feeling it. Sometimes bowel sounds can be felt if they are excessive. There is one important term which is known as borborygmi. Okay, borborygmi. Let me write that term for you. Borborygmi. Now, this borborygmi means excessive bowel sound, excessive peristaltic movement, which occurs in acute intestinal obstruction. Okay, so we can feel it. We can feel the movement of that peristaltic, movement. And we can definitely listen it. There's no doubt about it because it is so loud. Now, there are certain conditions where bowel sounds are absent. Very important questions from the exam point of view. So please pay attention. These are paralytic ileus, peritonitis, and any causes of shock, any type of shock, because there is decreased flow of blood towards the abdomen. So there will be ischemia of those intestine. Then also bowel sound will be absent. Peritonitis is a very important cause of absent bowel sound. And paralytic ileus means it may be caused by hypokalemia or after any major surgery of the abdomen. When the surgeon handles the bowel, when they touch the bowel, for a few days, bowel will be paralyzed. There will be no peristaltic movement. This is known as ileus. So there is absence of the bowel sound. And I'm sure many of the students know this fact. When we do surgery or operation, and when the person is admitted in the hospital, remember, we don't allow to eat or drink anything to the patient because there is no peristaltic movement. Whatever the patient eats or drink, it will be collected in the stomach or in the intestine, and it will cause a lot of discomfort to the patient. So the surgeon will keep on listening to the bowel sound, and once they are sure the bowel sound has come back or patient has passed the flatus or the gas, then they will allow the patient to eat. That condition is known as ileus. The bowel will recover on its own. You don't need to do anything there. Let's move on. Now, let's talk about some of the important physical findings in various causes of acute abdomen. Okay, this is a bit of clinical discussion again. So please pay attention. Perforated viscous. Now, perforated viscous means the GI tract has developed perforation anywhere. Okay, it may start from the stomach, it may be in the duodenum, jejunum, ileum, colon, okay, any part. So what happens if we examine that particular patient? The abdomen may be scaphoid, means it may be depressed downwards, just like a boat-shaped. Boat-shaped abdomen is called scaphoid abdomen. So the reason probably, is the contents of the GI tract, okay, have leaked outside, especially the gas. The gas has leaked outside into the peritoneal cavity. So the intestinal distension or the distension of the GI tract has decreased. So probably because of this, the abdomen is scaphoid only in the beginning. Later on, it will develop peritonitis, and because of that peritonitis, there is collection of the fluid in the peritoneal cavity. Then the abdomen may again be distended. It looks very tense, okay, because peritonitis is a part of perforation of the viscous. Now, let me tell a bit more here. If duodenum is perforated, what leaks outside? What is there as the content of duodenum? Yes, what is there in the first part of the duodenum?
Sir, in the there is
bile secretions.
The bile also goes to duodenum. So the bile goes to duodenum, so there can be the leakage of the bile.
No, my question is first part of the duodenum. First part, not second part. Okay, bile comes in second part of the duodenum onwards.
Yeah.
Yes. What is there in the first?
Degraded part of food.
And acid. Okay, and acid. Don't forget the acid there. The hydrochloric acid, which is secreted by the stomach, it is still not neutralized. It will be neutralized on the second part onwards because of that alkaline fluid which is coming there. Now, let's come to the point. If first part of the duodenum is perforated, which is very common, cause of perforation, then that hydrochloric acid will leak into the peritoneal cavity. Some food contents will also leak, there's no doubt. Now, in the beginning, we call it chemical peritonitis because of this acid reaction. But quickly, that chemical peritonitis will change into bacterial peritonitis. And during that time, all the features of peritonitis will be present. The abdomen is very tense, it is rigid, there is guarding, there is loss of the bowel sound, and all those things. So see this, there is a diminished bowel sound, only occurs in peritonitis. there is loss of liver dullness because of the leakage of the gas. The gas collects in between the dome of the diaphragm and the upper margin of the liver. So right dome of the diaphragm and upper margin of the liver, there is collection of the gas. And from where the gas has come there? Because of rupture or perforation of the viscous. And this can be seen in the X-ray. And during examination, there is loss of liver dullness. Guarding or rigidity are typical features of peritonitis. Now, if it is a bacterial type of peritonitis, the patient is motionless because this is a very painful condition. The patient doesn't want to move because movement will cause the pain. There is absent bowel sound. The cough and rebound tenderness means when the patient coughs, there will be pain. That is the meaning here. And rebound tenderness is strongly positive in case of peritonitis because the parietal peritoneum is inflamed. And the meaning of rebound tenderness is, okay, when you do the tenderness test, means we press that area, there will be pain, there's no doubt. But when we remove our finger, when we take away our finger, the peritoneum will jump back to its original position. That will even cause more pain. This is known as rebound tenderness. And again, guarding a rigidity would be there. Now, inflamed mass or abscess may be the cause of acute abdomen. So if that is the cause, then these are the physical findings. There is tender mass which can be palpated, okay, in the abdomen, in the rectum, or in the pelvic area, wherever the mass. So we can feel them there. There is punch tenderness, and there are special signs like Murphy sign, Schwarz sign, or even obturator sign. Now, Murphy sign is seen in acute cholecystitis. Schwarz or obturator signs are seen in acute appendicitis. Okay, Schwarz sign and obturator sign. In today's class, we are going to talk about them. Now, what about in intestinal obstruction? What are the findings? So there will be distension. There's no doubt. There are 4 cardinal features of intestinal obstruction. So if I ask that question, any student can answer them. One is distension. Another is vomiting. Another is constipation. And the 4th one is abdominal pain. So symptoms and signs are combined there together. Okay, but here we mainly talk about the signs. So there is visible peristalsis, which occurs in late cases of intestinal obstruction. This peristalsis is because of the contraction of the intestine there. Remember, in intestinal obstruction, what happens? There is an area, okay? There is an area where obstruction occurs. So proximal to that area, there is vigorous peristaltic movement. And distal to that area, distal to that area, there is usually the intestine will be collapsed because nothing is going distally. So this is a very interesting situation here. Proximal to the area of obstruction, there is vigorous peristalsis. There is contraction most of the time until it is completely paralyzed. So we can see that peristaltic movement and we can even feel the peristaltic waves. Hyperperistalsis occur in the early cases of intestinal obstruction and quiet abdomen occurs at the late. That's what I mean just now. How long the peristaltic movement can last? Not forever. So after a certain time, those intestines, they will give away. They think we cannot contract anymore. Then the abdomen is quite quiet, means the bowel sounds are absent that time. Because of the peristaltic movement, there is diffuse pain, but there is no rebound tenderness. Why is there no rebound tenderness in intestinal obstruction? Why? Yes?
Because there is no involvement of peritoneum.
Because there are no, basically, so no peristalsis happening in this case, so that's why.
There is no peritonitis, that's why. Very good. Exactly. I got the answer already. Very good. So this is very easy question. If you listen properly, these questions are very, very easy. This is a pure case of intestinal obstruction. There is no involvement of peritoneum here. Peritoneum is not inflamed. So why should there be any rebound tenderness? And herniation or some rectal mass may be the cause of intestinal obstruction. So we can feel them. because of those certain, procedures. Paralytic ileus is another, a condition which results in case of acute abdomen. So there is distension of the abdomen, definitely, because of the, distension of the intestine. There is minimal bowel sound or absent bowel sound, and there is no localized tenderness here. If the intestine have developed ischemia, or if there is a strangulated bowel, which is usually caused by strangulated hernia, okay, or volvulus, those type of causes, then it is not distended until late. The bowel sounds are variable. In the beginning, they may be present, but later on, they're definitely absent. There is severe pain, but little tenderness. Okay, this pain occurs because of, pathology of the intestine, and there is rectal bleeding. This mainly occurs in older people who definitely have some risk factors. So we need to find out those risk factors here. Risk factors may be heart disease. Heart may be the source of thromboembolism there, or they may have some risk factor for atherosclerosis. Now, if bleeding is occurring from the GI tract, then the person may be pale. The person may already be in shock. There's distension of the abdomen if the bleeding occurs in the peritoneal cavity. If aneurysm, a rupture aneurysm is the source of bleeding, then in the beginning there may be pulsatile mass. If ectopic pregnancy is the cause of bleeding, okay, the abdomen may be tender, and rectal bleeding may occur in many cases. So these are some of the, helpful signs according to the cause. So this is a very general type of discussion. Now we are entering into the very important part of today's class: how to investigate if a patient comes with acute abdomen to you. Okay. How to proceed further. Now see this. There are certain initial lab evaluation, okay, which we like to do all the time in a patient of acute abdomen. These are CBC, complete blood count. We do it all the time. What is the hemoglobin level? What is the hematocrit? What is the total leukocyte count? What is the differential leukocyte count? What is the platelet? We want to know. There are so many examples I can give here. In acute appendicitis, there is leukocytosis with neutrophilia. So that really helps us in the diagnosis. Electrolytes, okay, they are usually done in case of GI illness. Serum electrolytes, if they are, abnormal, or if the values are very low, or sometimes a bit high also, it depends what type of, fluid the patient has lost. So we need to replace them. So electrolytes are usually done. Amylase and lipase are, altered in case of acute pancreatitis. Okay, you all know that. These are the enzymes which are secreted by exocrine part of the pancreas. Amylase and lipase. Amylase is the enzyme which digests carbohydrate, and lipase digests fat. And they leak outside in case of acute pancreatitis, and they are raised in the blood. Never forget them. They are the very important test in the diagnosis of acute pancreatitis. Now, ECG is done to rule out myocardial infarction and also as a preoperative baseline cardiac assessment. Now, in the last class also, I clearly told about this. If our patient is, okay, more than 30 to 35-year-old, and if they present with abdominal pain, we should always rule out ischemic heart disease, okay, like angina or myocardial infarction. Always. Never send them home without doing ECG. That is one reason. And another one, for example, they are really having surgical causes of acute abdomen. But we want to know what is the status of the heart. Do they have any cardiac condition or not? So one, ECG can be done as a preoperative baseline cardiac assessment. So these are the two important reasons here. And if the patient gives the history of heart disease in the past or present, okay, there is no doubt ECG should always be done. Liver function test for right upper quadrant pain. So liver function test is done if there is certain history, if the patient gives history of right upper quadrant pain like cholecystitis, like gallstone, like hepatitis, isn't it? Like obstructive jaundice, for example, liver function test should be done. So what are the parts of liver function test, or what are the components? Yes?
AST, ALF, AST, ALF, ALT, and bilirubin,
Checking the liver enzymes.
Very good. Very good. So different answers are coming. Excellent. So they are total serum bilirubin, okay, and the direct component. And we calculate indirect by subtracting the direct from total, the first one. Second, liver enzymes. Liver enzymes. There are different types of liver enzyme we have, like AST, ALT, and ALP. These three are the major one. Okay. AST, ALT, and ALP. These are the liver enzyme. The third one, okay, on our list is serum albumin. Exactly, serum albumin level. Don't forget that. Okay, and another one is prothrombin time, PT. So if you remember these four, almost 90%, the parts of the liver function test are included inside here. The examiner will be extremely happy. And then they may ask some here and there questions, which you can handle very easily. Now, let's move further. Another type of investigation we do is beta HCG. Okay, and this is done in all women of childbearing age if they come with acute abdomen, because ectopic pregnancy has to be ruled out. Ectopic pregnancy is a very important cause of acute abdomen in the woman or in the female of childbearing age. So never forget this. And this is very easy. Just, check urine for beta HCG analysis. Chest X-ray and abdominal X-ray are done to look for free air under the diaphragm. This is known as free air under the diaphragm, or also known as pneumoperitoneum. Pneumo is the term we use for air. Okay, if free air is present in the peritoneal cavity, this is called pneumoperitoneum. Now see here, it can detect as little as 1 to 2 ml of the air. And we always take this type of X-ray in the erect posture, which patient should stand. Then only the gases will go upward and collect below the diaphragm. And we can utilize this very important, concept for the diagnosis of pneumoperitoneum. Now, one small question here. How the gases reach there? What is the source of that gas? From where it comes?
Perforated viscous in many cases, sir.
Exactly. It is because of perforation. So, okay, from today onwards, please have this concept in your mind. If you see free air under the diaphragm, this is a case of perforation of GI tract. The perforation can occur anywhere inside the abdominal cavity, stomach, duodenum, jejunum, ileum, colon, whatever, So we have to find out where exactly is the perforation. So this is the job of the surgeon. Now, some more information here. There are two domes of the diaphragm, right and left. So it is easier to see under the right diaphragm because towards the left dome of the diaphragm, there is fundus of the stomach. And in that fundus of the stomach, there is always some amount of gas collection. So that fundic gas may obscure, okay, the gas which is collected below the left hemidiaphragm. So sometimes, we get confused. Which gas is this? Is this the normal gas which is, lying inside the fundus of the stomach, or is it the gas which is collected below the left hemidiaphragm? But when you become experienced, you can find them. But in the beginning, it may a bit of confuse you. That's why always see the right hemidiaphragm first and then comes towards the left. Abdominal CT should be used after the above assessment is complete and the diagnosis remains elusive. You have done all these tests, still you don't know what is the diagnosis. Go for abdominal CT, very commonly done these days for the investigation of acute abdomen. Let's move on. Now, what are the other blood tests you do apart from those which are listed? Some clotting study we have to do. Okay, see this, the clotting study, and they are done in acute pancreatitis, septicemia, and disseminated intravascular coagulation, as well as in the history of bleeding disorder, or if the patient is an anticoagulant therapy or liver disease. Now, every student know that. And what are the parts of this clotting study? So let me, talk a little bit about them. We always starts with CBC because platelet is a part of our CBC. Okay, we have done that. Second is bleeding time and clotting time. We do that. If bleeding time and clotting times are abnormal, then only we move further. If they are normal, we don't need to do any other types of clotting study. Okay, always remember this. So if bleeding time is prolonged, probably it is a disorder of platelet. And if clotting time is prolonged, now I need to find out something more here. Okay, I need to find out something more. Sorry. See here. Okay, so I was talking about this one. So if bleeding time is prolonged, then probably this is a case of platelet disorder. But if clotting time is prolonged, then after that we'll go for some other test like APTT. Sorry, let me, okay, it is here. Then APTT and PT. Okay, what is APTT? What is the full form of APTT here?
Sir, it is activated partial thromboplastin time.
And it signify what? If it is prolonged, what does that mean?
Like sir, it is like that. Basically, it's the inability to produce a blood clot, sir. In that case, if it is excessively prolonged.
Okay. Now remember, these APTT and PT, they measure two parts of the coagulation pathway. APTT measures the intrinsic pathway, and PT measures the extrinsic pathway. Okay, so whatever factors comes under intrinsic pathway, if they are deficient, then APTT will be prolonged than the normal, and PT, okay, just like that in the extrinsic pathway. So we go for this, and after these are abnormal, then only you go for factor analysis. So there is always a pattern you need to follow. Never order factor 8 in the beginning or factor 1 in the beginning. This is not the way. You should always follow a particular pattern, or you should have plan in your mind what are you going to do. This is known as clotting disorder study. Okay, so these are the different indications. Let's move on. Now we have to go for urine test also. These urine tests are done by routine examination of the urine. Okay, microscopic examination of the urine. We go for culture and sensitivity, especially for the diagnosis of UTI like pyelonephritis. And even pregnancy test is a part of urine test because that beta HCG is these days usually done in urine. Okay, we can also do that in the blood, but urine is always more practical than doing the blood test. Let's move on. Now, what is the role of radiological test for the diagnosis of acute abdomen? Chest radiology or chest X-ray should be taken in the erect view to look for gas under the diaphragm. Already talked about. It's a very important one. And plain abdominal X-ray should also be taken. Plain abdominal X-ray. Now, this plain abdominal X-ray is also taken in the two different, position. One is erect, another is supine. Erect view is also important. In case of acute intestinal obstruction, we can see the air fluid level if we take the erect, view. In case of plain X-ray of abdomen, and supine, we can see the distension of those intestine, the pattern of intestinal obstruction, and all those things. We'll talk about that in the particular class. Ultrasound is a very important test in case of acute abdomen. Okay, it will give you a lot of important information. So ultrasound is routinely done if something happens in the abdomen. Just remember that much. So if it is suspected pancreatitis, even appendicitis, gallstone, cholecystitis, any gynecological pathology, most of those cases we can have a lot of important idea by doing ultrasound. IVU. What is the full form of IVU? Anyone? This is called?
Sir, intravenous urography.
Exactly. Intravenous urography. Intravenous urography. So let me write that for you because you may get confused, later on. Intravenous urography. Now, the name itself suggests we give a dye inside the vein, okay, and after some time we take the X-ray. That dye is excreted by the kidneys, and that dye will flow into the urinary tract. If there is any obstruction of the urinary tract, so there will be obstruction of the flow of that dye, and we can suspect something is there. So this type of test is called IVU. So if you suspect any renal or ureteric colic caused by stone or any other obstruction, you can go for IVU. Now, CT scan, I already talked about, is very commonly done these days for the investigation purpose. And contrast CT, okay, is a type of CT. There are two, plain and contrast. Contrast is always better because there is a difference of the density. So for the most optimal imaging, both oral and IV contrast is used in case of CT. In some cases, such as impaired renal function or allergy to IV contrast, we have to take the history, remember, before injecting any substance to our patient. We have to ask, are you allergic to any substance, any drug, anything in the past? And if they say yes, then we should avoid it if this is the substance. Otherwise, you can go further. Non-contrast CT, although suboptimal for the most cases, except nephrolithiasis, still provides lots of information. So if you really cannot give contrast because of this history or because of the contraindication, you can simply go for plain CT, and that is also highly informative for us. Now, all the students, please focus on this X-ray. What can you see here? See this, please. The diagnosis is already written there, but
Yes, sir.
all the time I tell you, don't only look at the description. You have to look the X-ray. You have to identify where is the problem. Now see this, look at the arrow part here. You can see a thin rim of air here, isn't it? Above that, yes, there is a diaphragm. You can see this is the right dome of the diaphragm. Okay, this is the right dome of the diaphragm. So below that, I can see one extra black line here. This is the collection of air under the right hemidiaphragm. And see this. Similarly, here is another one on the left side. Okay, so this occurs because of rupture of the viscera or because of perforation of the viscera. So this is known as pneumoperitoneum. And you have to always take this X-ray in the erect posture, which patient should be standing. Now, some of the important points, okay, a bit of, take-home messages for you. In case of, adult more than 30 to 35-year-old, if they present with acute abdomen or abdominal pain that mainly occurs in the epigastric area, never forget to do ECG. You will save the life of many patients if you remember this. But if you ignore, sometimes what happens, you are overconfident. You think, oh, this is a plain case of gastritis or peptic ulcer disease. Why should I do ECG? Never talk or even think like that. We are never 100% sure of our diagnosis. That's why the concept of differential diagnosis is there in medicine. Differential diagnosis means even if we make mistake, some extra things are there which we are thinking. So who knows? This may be a case of MI, and ECG will pick that, and you can save the patient from untimely death. Pain of pancreatitis is described as boring and radiating straight to the back. So history alone can give you the diagnosis if you take it properly. Boring means, it is deeply going inside, and that is towards the backside. Now, can you look at this X-ray? What can you see here? See this, please.
There is a gas, white here.
Gas under which dome of the diaphragm?
Right. Right.
Right dome.
Right dome.
Right dome.
Very good. Under the right dome of the diaphragm. Now, you all know there is a liver here. This is the area for liver, and liver pushes the right dome of the diaphragm a little bit higher than the left. Left dome of the diaphragm is lower than right dome of the diaphragm. And this is never the shadow of liver. Liver looks white in X-ray. So this has to be the gas here. And I can still see this white, tissue density. This is the dome of the diaphragm. So clear cut, there is a gas shadow below the right dome of the diaphragm. This is called pneumoperitoneum, and this is the diagnosis. This is definitely the erect one because I can see the air fluid levels here. See this, there's a straight line. Above that, this is an air shadow. Below that, okay, this is a fluid, and fluid is seen a bit whitish on the X-ray. So a lot of air fluid levels are seen. So this is the case of acute intestinal obstruction, again in the erect view of the plain X-ray abdomen. This is definitely erect view. Look at this fundic air shadow. This is called fundic air shadow, the air fluid level. And at the same time, look at this. There are a lot of other air fluid levels also. So this is also a case of acute intestinal obstruction. These are a stack of coin appearance I can see. So this is a small bowel obstruction. Now, how to manage a case of acute abdomen? Very important concept, so please pay attention. Sometimes these patients are very sick, okay? They are in shock. They are in peritonitis, and peritonitis can easily give rise to septic shock. And sometimes a huge amount of bleeding may occur from our GI tract, which can result in hypovolemic shock as well. So airway management is very, very necessary. So you all know how to manage the airway. There are different ways. One is positioning of the patient. Positioning, that is head tilt, chin lift, and jaw thrust maneuver. Head tilt, chin lift, and jaw thrust maneuver. This is the positioning to open the airway. Second, endotracheal intubation. Okay. Third, oral tube placement. That is a different way. High concentration oxygen is given, especially if the patient is very sick or the patient is in sepsis or shock. Anticipate vomiting, because this is very common in case of acute abdomen. And if the patient is drowsy, okay, or a little bit, going towards the unconsciousness, easily aspiration can occur because of this vomiting. And aspiration pneumonia is a very lethal, condition. Anticipate hypovolemia. If already, restore it by giving crystalloid solution, ringer lactate, and normal saline are the one. If there is a massive amount of bleeding, you can go for blood transfusion. Nothing is given by mouth. This is called nil per oral, NPO. Okay, very commonly used surgical or medical term, NPO, nil per oral, nothing by mouth. Now, why is this? Why we don't give anything by mouth here? What's the reason?
Because there is already obstruction.
We already have some sort of airway obstruction, and so we already have some sort of a distress in our airway. So if we can give in that, can also occur some sort of a further distress. So sorry, that's why we not give anything by mouth.
Okay, good. So see there, I can getting different answers here. Very good. So you are thinking in a good track. That's what matters to the teacher. You may not be able to give all the answers, but that track should be nice, or the right one. There are so many causes of acute abdomen. Some causes are infective or inflammatory. Some are obstructive. So Who knows? This patient may need surgery anytime. Maybe after 2 hours, the patient may need surgery. Okay, or after 4 hours, the patient may need surgery. And whenever we take the patient for surgery, we want the stomach to be empty. Remember this. We want stomach to be empty. Otherwise, there is a high chance of aspiration. That's why do not give anything from mouth if acute abdomen is suspected. This is the most important reason here. And another one, if already, a paralytic ileus has developed, if already there is loss of bowel sound, if there is no peristaltic movement, then if you give anything, it will be collected there and there is a high chance of aspiration again. So do not give anything. No analgesics or sedatives are given in case of acute abdomen. Now the question is again, why? Why is this? Why you don't want to give analgesic? The patient is having a lot of pain. Why you don't want to give? Any answer? Anybody?
Like, sir, for example, like, sir, we are having paralytic ileus, sir. Sir, in the paralytic ileus, sir, already the muscle, sir, the muscle are not doing the peristalsis. Sir, we, for example, any type of analgesis, sir, it will even further relax the muscle, and sir, it will cause even further complications. So that's what I have in mind for that.
Okay, fine. Any other student? Anybody else?
So there is vomiting. So if the patient is in sedation, it will come.
Very good. That is one good point you have brought. One more student, please. Anyone else?
And sir, some sedatives and analgesic have the effect on GIT mortality. That's why we increase the pain.
Okay. Now let me explain. Okay, this doesn't have a very important reason. It's just a bit of common sense here. Now think of a situation. You are in emergency department and a patient comes with acute abdominal pain. You are not sure what is the diagnosis till that time. You're not sure. So don't want to suppress those physical findings and symptoms from the patient side until and unless you make your diagnosis. So your consultant is on the way. Do not give very powerful painkiller, and when the consultant comes, when he or she is examining, there are no physical findings present because you have already suppressed the pain. We don't want that to happen. So until and unless you make the proper diagnosis, no analgesics or sedatives are given in a case of acute abdomen. That is the reason, because it may hamper our diagnosis. For example, by giving a very strong analgesic, remember when you are doing a rebound tenderness test, it is absent. Now, how can I diagnose acute appendicitis if rebound tenderness is absent? The patient may suffer furthermore because of this. Delay in diagnosis can rupture the appendix. It can lead to peritonitis and all those things. So before you make your final diagnosis, do not give analgesic to suppress the physical finding. But after you make the diagnosis, definitely it is given. Now let's move further. In adults who are more than 30, consider the possibility of referred cardiac pain. And to rule that out, we have to go for ECG. Already talked so many times. And in female, consider the possible gynecological problem, especially the ectopic pregnancy in the fallopian tube. That is ruptured ectopic pregnancy. So pregnancy test has to be done. And urine pregnancy test is very easy to do. Now, the definite management for acute abdomen is surgery, okay, or urgent surgery. There's no doubt about it. So what are the indications? Let's talk about it. This is a very important part of today's lecture. What are the indications for surgery in case of acute abdomen? If these physical findings are present, then we have to go for surgery. Involuntary guarding or rigidity, especially if spreading. It clearly tells us the peritonitis has already occurred, and especially if it is spreading, the generalized peritonitis is going to happen. So we have to open quickly. Increasing or severe localized tenderness. In case of acute appendicitis, let's take that example. The tenderness is localized to the right iliac fossa. If it is increasing, means the bigger and bigger area, okay, is involved. That means the peritonitis is again spreading. Tense or progressive distension, already the peritonitis has happened. So open as soon as possible. Tender abdominal or rectal mass with high fever or hypotension, open it to find out what is the cause there. Rectal bleeding with shock or acidosis. You probably cannot control this rectal bleeding from outside, and patient has already developed shock, and this acidosis is because of shock. This is a type of metabolic acidosis. So you don't have any option left apart from surgery. Equivocal abdominal findings along with these features, like features of septicemia, high fever, marked or rising leukocytosis, mental status change, or increasing glucose intolerance in a diabetic patient. Now, what do you mean by this? Equivocal means positive or negative finding. You cannot really tell what is the diagnosis here. Plus minus findings are there. You cannot pinpoint what is occurring. But if this patient is having these features along with equivocal abdominal finding, then the complication chance is very high. Okay, so better to open the abdomen. Another one is bleeding. Bleeding like unexplained shock or acidosis or falling hematocrit. By the medical management, we cannot control it. So only option left is surgery. Suspected ischemia, you go for surgery. These are the findings: acidosis, fever, and tachycardia in a relatively older patient who has some risk factors involved, and deterioration and conservative treatment. A good example I can give is appendicitis. These days, if the appendicitis is detected quite early, we can go for conservative antibiotic treatment also. But if that patient is deteriorating, then there's no option left rather than surgery. So these are the very good indication. Let's move on. Now, these are the indications for urgent operation in patient with acute abdomen if these radiological findings are present, if these endoscopic findings are present, or if these paracentesis findings are present. This is another very important concept for you. So please pay attention. Now, if you take the or do the X-ray, okay, or take the X-ray, and if these are the findings, then you have to do laparotomy and find out the cause, like a pneumoperitoneum. Very easy to diagnose by taking, erect chest X-ray or abdominal X-ray, which involves both the dome of the diaphragm. Easy to diagnose, but the thing is, what is the cause? Is it perforation of the duodenum, the first part of the duodenum? Is it perforation of ileum? Is it jejunum? Or is it large intestine? That is the main problem for us. Okay, and how to do that? By opening the abdomen, open the peritoneal cavity, examine the bowel, and try to find out. Gross or progressive bowel distension, if you have diagnosed that by X-ray, this is a feature of intestinal obstruction. Free extravasation of contrast material, again, this is the feature of rupture or perforation. Space occupying lesion on scan with fever, maybe abscess, who knows, and mesenteric occlusion on angiography. There is a clear-cut case of mesenteric occlusion, so if we can detect early, we can go for the removal of that. For example, big thrombus, thrombectomy can be done. So all these things are there. And another one, if it is too late, we can go for the resection of the bowel. If endoscopic findings show perforated or uncontrollably bleeding lesion, we have to go for surgery to control it or to treat it. Any paracentesis findings show there is a blood in the peritoneal cavity. If there is a bile, if there is a pus, if there is a leakage of the fecal matter, or if there is a collection of the urine, what does that show? That shows there is a rupture of the urinary bladder or rupture of urinary tract. There is perforation of the bowel. There is peritonitis. There is leakage of the bile from the biliary duct or from the gallbladder, and there is trauma. This is known as hemoperitoneum. all of these are very strong indication for laparotomy or opening of peritoneal cavity. Okay. What is paracentesis? What is that? Anyone?
Sir, paracentesis is a technique, sir, in which we take fluid through a needle from a space. Sir, for example, from peritoneal cavity, sir, we take some fluid through a syringe. So this is known like paracentesis.
By some catheter.
Okay, good.
Sir, these are the findings through which we can we have to aspirate those fluid from that place.
Okay, now you're absolutely right. Okay, but you need to be very particular here. Paracentesis is the term we use for peritoneal cavity only. So that's what we are talking right now. Okay, this is the aspiration of peritoneal fluid. That's it. So if a peritoneal fluid is aspirated, and if the content are like that, then we should be very serious. This is not normal. That means something horribly wrong has already occurred. So we use the different term for other body cavities. Like for the pleural cavity, we call it thoracocentesis. Okay, thoracocentesis. And for the pericardial cavity, we call it pericardiocentesis. But for the peritoneal cavity, we use the term paracentesis. Let's move on. Now, okay, towards the end of this important topic, I have collected some of the very important sentences regarding some common acute abdomen. So let's go through them quickly. In case of appendicitis, okay, that is another class. In the second half of the class, I'll start appendicitis today. But let me talk a little bit about this now. It is usually due to the obstruction with fecalith. Okay, fecalith, hard fecal matter, almost act like a stone there. It may be the obstruction, in the appendicular lumen. Then all the process will follow after that. Appendix becomes swollen, inflamed, gangrenous, and possibly it perforate at the end. And this leads to peritonitis. In the beginning, the pain start from the periumbilical area. Then later on, it moves to right lower quadrant. That means right iliac fossa. This is a peritoneal pain. And in the beginning, this is a visceral pain. The visceral pain is vague. It is around the periumbilical area. But later on, after the involvement of parietal peritoneum, the pain will move on to the right iliac fossa or right lower quadrant. Patient is having nausea, vomiting, and anorexia, very non-specific features. Patient lies on the side. Right hip and knees are flexed. If right hip is extended, okay, then the patient may have pain, especially if the appendix is located there. In a retrocecal type of appendix, the pain occurs in this examination. This is called Schwarz sign. Schwarz major is the muscle which is the flexor of the hip joint. So if we want to make that muscle stretch, we need to go for the opposite type of movement, that is extension. So extend the hip, and if the patient feels pain in the right iliac fossa, that means this may be a case of acute appendicitis. This is called Schwarz sign. So pain may not localize to right lower quadrant if appendix is present in the odd location. Now I'll give you one perfect scenario here, that is in pregnancy. During pregnancy, if that pregnant lady develops acute appendicitis, she may feel the pain in right upper quadrant, because of displacement of the bowel, upwards because of the growing uterus. So this is a very atypical type of presentation there. And if the patient was having severe pain and suddenly there is relief of the pain or disappearance of the pain, probably appendix has perforated. And after some time, another severe pain will start, and this is the pain of generalized peritonitis. Rest of the thing will be talked in the particular topic. Now, duodenal ulcer disease is another cause of acute abdomen. So in this case, there is a steady, well-localized epigastric pain, because first part of the duodenum is the commonly involved area. There is burning, gnawing, or aching type of pain. These are called, quality of the pain. Okay. Burning and gnawing. Gnawing means, deep boring type of pain. And this type of pain occurs, in a very deep type of ulcer. The pain in case of duodenal ulcer is increased by taking coffee during the stressful situation, by taking the spicy food, and by smoking as well, because all of these are associated with increased acid output, and hydrochloric acid is the main culprit here. It is decreased by alkaline food and antacid, okay, because it neutralizes the acid. It may cause massive GI bleed, there's no doubt about it. It is a very important cause of upper GI hemorrhage. And one of the very important complication is it can perforate. And when it perforates, the pain is very intense. Okay, the pain is very intense, means very severe pain. And it's a constant type of pain now because generalized peritonitis has already happened. Patient lies very still with rigid abdomen. Okay, this rigid abdomen is a feature of peritonitis. So what should we do now? We first need to confirm the diagnosis. Okay, then as soon as possible, we take the patient into operation theater and open the abdomen. This is known as laparotomy. We find out where is the leakage or perforation. We patch that area and wash the whole abdominal cavity. This is the treatment. Let's move on. Another cause of acute abdomen is a kidney stone. Many students know use a lot of information about kidney stone. It is often associated with history of recent UTI. Definitely, kidney stone can lead to recurrent UTI. Severe flank pain occurs in case of kidney stone, and that flank pain radiates to groin, or sometimes even reaches the scrotum in case of male. That's why we use the term loin to groin pain in case of kidney stone. Loin is the place, okay, where the kidney is located. Means loin means lumbar region. So pain starts there and it is radiating towards the groin. Groin means inguinal region. Highly typical of kidney stone. Sometimes the kidney stone may dislodge and go to the ureter also. There is nausea, vomiting, and hematuria, very common features. This vomiting and nausea is because of severe pain, whereas hematuria because of the stone which is lodged there. And patient becomes extremely restless because of severe pain. This is one condition where pain is a lot, especially in ureteric stone, the pain is a lot more than the kidney stone. Another cause may be abdominal aortic aneurysm, a rupture of abdominal aortic aneurysm. You understand like that. So we all know aneurysm is a localized weakness of the blood vessel wall with dilation. In this case, the blood vessel is abdominal aorta. Now, before the rupture, we can find a pulsating mass in the abdomen. Okay, pulsating mass in the abdomen. But even after the rupture, only one part of that big blood vessel is ruptured, right? So the aorta is a very strong vessel. So here and there, the pulsation can still be felt. It can cause lower back pain, and if the aneurysm is ruptured, the patient will die. There is high chance of death because of hypovolemic shock, which we call it exsanguination. Okay, a lot of blood can be lost in the peritoneal cavity, and in no time, patient develops hypovolemic shock. If you fail to diagnose this in time, we'll lose that patient definitely. This is a very serious condition. Pancreatitis is another important cause of acute abdomen, okay, especially the acute pancreatitis. Definition wise, this is inflammation of pancreas. Now, common causes of acute pancreatitis are gallstone and alcohol consumption. Apart from that, hyperlipidemia and trauma are some other causes. Now, this disease may be triggered by ingestion of large amount of fatty food. Okay, this large amount of fatty food is actually associated with this gallstone and things like that. or even hyperlipidemia is associated there. The patient will have nausea and vomiting, abdominal tenderness. The pain radiates from upper abdomen and straight through to the back. This is known as boring pain, which is going towards the backside. Now, if you take a good history, you can always think about pancreatitis right from your history. Okay, and confirmation is done by enzyme assay, like serum amylase and serum lipase. They are very high. The patient develops hypovolemic shock here. Now, can anybody tell me why hypovolemic shock occurs in pancreatitis? What is the reason? Anyone?
So because due to vomiting.
Okay.
Because of vomiting.
Okay, now this is a bit of a difficult question, so let me explain this. Vomiting contributes to the hypovolemic shock, but vomiting alone, cannot give hypovolemic shock. Probably it may contribute a bit of dehydration. Now, what is happening here? In case of acute pancreatitis, there is a release of a lot of cytokines. These cytokines, okay, are circulating all over the body, and they can cause increased capillary permeability. That increased capillary permeability causes leakage of fluid everywhere in the body. That is the cause of hypovolemic shock here. So this is a very important mechanism. You will know this when we talk about the topic proper. Cholecystitis is another cause of acute abdomen. This is the inflammation of gallbladder. It is commonly associated with gallstone, definitely. But sometimes there is acalculous cholecystitis also occurring in a debilitated and old patient. This is more common in female who are between 30 to 50 years, and it is very common in obese type of female. Regarding the clinical features, there is nausea and vomiting, right upper quadrant pain, and tenderness, as well as mild grade of fever. This tenderness of right upper quadrant during the examination is known as Murphy's sign. Murphy's sign is present in acute cholecystitis. All these are special topics in surgery, okay? In sixth semester, we give a lot of time to the GI surgery, okay? So according to the reason, we talk about the surgical aspect. So this will definitely be one of the important topics then. The attacks are triggered by ingestion of fatty food here. Now, what is the relation of fatty food and gallbladder? You all know when we take the fat, okay, to digest the fat, we need bile, and bile is stored in the gallbladder. If that gallbladder is already inflamed, because of the contraction of that inflamed gallbladder, there will be pain. Now, lastly, bowel obstruction or acute intestinal obstruction is the very important cause of acute abdomen. And the meaning is there is obstruction or blockage of inside of intestine, maybe small, maybe large. Small bowel obstruction and large bowel obstruction, there are two types. There is an interruption of normal flow of contents. That's why we call it bowel obstruction. Now, the classical features of bowel obstruction are four. One, colicky or crampy type of abdominal pain. Colicky or crampy type of abdominal pain. You see this? We have explained this so many times, so students are quite confident now. Vomiting, okay, nausea is a part of that. Abdominal distension. And what is the fourth one? Yes? What is the fourth one here?
Constipation.
Constipation, sir.
Excellent. Constipation, okay, which is not written, but I'm sure you already know that because I've explained this so many times. Whenever the term obstruction of the bowel comes, I always take these four points there. Abdominal pain, which is colicky or crampy, vomiting, constipation, and abdominal distension. This vomiting may be a fecal matter if large bowel is obstructed. If small bowel is obstructed, it depends where is the site. If the obstruction is, okay, before the first part of the duodenum or second part of the duodenum, I should say, there is no bile in the vomiting. But if the obstruction is beyond or below the second part of the duodenum, bile is already present there, so vomitus usually is green in color. Never forget to ask this important question which you are taking the history. So this are some of the important features of bowel obstruction. When we examine this patient, okay, in the beginning, the bowel sounds are hyperactive because of increased peristaltic movement. But after some time, there will be no more peristaltic movement of the bowel, so bowel sounds would be absent. Please listen properly. In the beginning, they are hyperactive. It is known as borborygmy. Later on, they are absent. This is a highly typical case scenario of bowel obstruction. Okay. Regarding the diagnosis, you need to take erect and the supine, plain X-ray of the abdomen. That will give you a lot of information. And treatment is open the abdomen, which is called laparotomy. Find out where is the problem and go for the correction.